We have a 62-year-old woman with a history of AML, currently in remission, who presents with new onset headache, blurred vision, and shortness of breath. She recently completed consolidation chemo 3 weeks ago. On exam, she is tachycardic, mildly hypoxic, and has diffuse crackles on lung auscultation. Which lab test would be most helpful in identifying the cause of her symptoms? CBC, D-dimer and coags, ABG and lactate, or BNP and troponin? So the answer would be CBC with differential. And while you might get the other studies, we're going to dive into this a little bit. Let's talk about leukostasis. Leukostasis is a hyperviscosity and microvascular occlusion due to an extremely elevated white blood cell count. And so thinking of the endothelium and the vessel as a pipe, when there's sludge in the pipe, there is low flow. When there is low flow, there is poor oxygenation and you get damage. This is most commonly seen in AML when the white count is over 100 and the blast count is high, and that's really important. The blast count is high. The blast cells are the ones that are rigid and are large, and those are the ones that make this quote-unquote sludge. Chronic leukemias are less commonly causes of leukostasis, so it can be a cause, but not always. So let's think about how leukostasis presents. And so understanding that the white count is greater than 100 and the LDH is often elevated, let's break down the symptoms, the exam, the specific labs, and other diagnostics. Starting with the brain, things like headaches and confusion can be seen when the patient's telling you symptoms or from report from family. On exam, they can look altered, they can have focal neurodeficits and papilledema. There are no specific labs, but on imaging you might see infarcts and hemorrhage. Second is lungs. And so the patients might have dyspnea or cough. On exam, they'll have tachypnea. They might have some cyanosis and rales. They might have decreased breath sounds throughout. And then when you put a pulse oximeter on them, they might have hypoxia. If you get an ABG, you might see hypoxemia and a respiratory acidosis. If you were to get a chest x-ray, you might see bilateral or focal opacities. And finally, on CT, you might see GGOs, septal thickening, or pleural effusions. Another organ that can be affected is the kidneys, and so patients might be complaining of decreased urine output. And on exam, you might see evidence of volume overload. That would be an elevated JVP, sacral edema, pitting edema of the legs, and shortness of breath. And so there's a little bit of overlap between lung and kidney pathology here. If you were to get a creatinine, you would see an AKI, and you might see some proteinuria as well if you get a UA. Finally, if you happen to get a renal ultrasound, you might see some infarcts of the kidney. Finally, the heart. So you might get some chest pain and irregular heartbeats. Remember that there's poor flow in the vessels, and so you get microvascular complications, so ischemia to the heart. And so you can get tachycardia, and if there's a severe enough MI, you might actually get hypotension. You might see this as an elevated troponin or BNP. However, this is actually not commonly seen. So cardiac manifestations of leukostasis are a lot rarer. Nevertheless, an EKG might show arrhythmias or evidence of myocardial infarction. So once you identify leukostasis, this elevated white count, and you have a suspicion based on symptoms and labs and imaging, what should you do? Well, there's immediate therapy, which includes IV fluids to really make sure that the patient is well resuscitated, and oxygenation. The idea being that if there is poor oxygenation to the distal vessel, if you increase the arterial oxygen content, you might improve that a little bit, even if you're not fixing the sludge. Next is cytoreduction, and the two ways to do that are leukophoresis, which is removal of the white blood cells, so you don't have as many, and then chemotherapy can actually help too. In terms of which one you do in what order, that is pretty controversial, and I would recommend talking to the oncologist about this. So in summary, leukostasis is a hyperviscosity syndrome that causes microvascular occlusion because there are a lot of white blood cells, and it's usually seen in AML. The white cell count is greater than 100, and you have a high blast count. And chronic leukemias are less likely to cause this. There are lots of possible presentations, including neurologic, pulmonary, renal, and cardiac. And finally, the management immediately is IV fluids and oxygen. And then the second thing to do is call your hematologist oncologist and ask if leukophoresis and/or chemotherapy are indicated.